No history of hemodialysis or peritoneal dialysis. No history of recent vaccination or dog bite. So with this history, what are the clinical possibilities? It could be an hypoglycemic coma. It could be due to electrolyte imbalances. The patient could have had a seizure episode, which could be missed by the family members, and this can be a post-ictal confusion. And since the patient is on dual antiplatelets, it could have been a massive intracranial bleed. It could be a brainstem infarct. It could be Wernicke's or the other metabolic encephalopathy or septic encephalopathy. It can be meningitis or meningoencephalitis. So moving on to examination.
How to differentiate between encephalopathy and encephalitis? Okay.
Yes, sir. Encephalopathy is a non-inflammatory condition, sir, whereas in encephalitis, there is a definitive involvement of the brain parenchyma, and also the imaging studies and CSF analysis will be normal in encephalopathy, but in encephalitis it will be deranged.
Okay.
So moving on to examination, general examination, the patient was moderately built and moderately nourished. BMI was 19.6. Pallor was present. No icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. No rashes over the body, which was searched in view of meningococci. Fundus showed bilateral papilledema. Vitals, the patient was afebrile during the time of examination. BP was 120/80, measured in the right upper limb in supine position. Pulse rate was 91 per minute. It was regular rhythm and normal volume. No radioradial or radiofemoral delay. The respiratory rate was 18 per minute. It was thoracoabdominal and it was regular. CNS examination, the patient was drowsy, not responding to oral commands. Wincing to pain was present. Doll's eye movement was present, ruling out brainstem involvement. Memory and speech could not be tested considering the patient's situation. And cranial nerve examination, there was papilledema, and there was no facial act or painful stimulus. Gag reflex was present, no tongue deviation or waste. Motor system examination, bulk was normal, tone was normal. Power could not be assessed, but the patient was observed moving all four limbs equally well, spontaneously, and also to painful stimulus as well. Movement against gravity was also present. Reflexes, superficial reflexes were normal. Plantar was equivocal on both the sides. Deep reflexes were well elicited. Sensory system examination. The sensory system examination was limited due to the patient's status. Patient winced in response to pain along all the dermatomes. Cerebellar examination, testing for nystagmus, intentional tremors, dysdiadochokinesia, scanning speech was limited due to the patient's status. No pendular knee jerk was observed. Skull and spine were normal. Meningeal signs, the most important slide of this presentation. Neck rigidity was present. The patient was unable to put the patient's chin on the chest by passive flexion of the neck. And Kernick's sign was positive. The patient was unable to straighten the knee on flexion of hip joint and extension of the knee joint. Brudzinski's neck sign and Alex sign were positive.
What is the importance of the test?
Sir, Kernick's test is based on the principle of stretching of the nerve roots. Stretching because of meningeal irritation, the nerve roots exiting out of the spinal canal will be inflamed, and due to pain relief, the patient will be flexing the hip and knees.
Okay, proceed.
Moving on to examination of the respiratory system. Upper airway was normal. Trachea was in the midline. Chest movements were equal on all the areas. No crowding of ribs. On auscultation, bilateral diffuse inspiratory ribs were formed. Other system examination. CVS S1 S2 hurt. Perabdomen soft and non-tender. Summary of the diagnosis. This is a case presenting with features of meningeal irritation with signs of lower respiratory tract infection. This is a case of a recent CVA with type 2 diabetes mellitus and chronic kidney disease. Provisional diagnosis is a case of bacterial, viral, or tuberculous meningoencephalitis with lower respiratory tract infection with diabetes mellitus, CKD, and recent CVA. Moving on to...
How will you clinically differentiate between meningitis and meningoencephalitis?
Sir, in meningitis, the primary presentation of the patient will be like headache, vomiting, neck stiffness, sir. Whereas in encephalitis, the patient will be presenting in an altered sensorium with seizure, and some patients may present with coma also.
Okay.
Moving on to investigations, HB was found to be 9.3. There was a microcytic hypochromic anemia, and the total count was 8,500. And the CRP was positive 10.5, indicating that there is a focus of infection. And electrolytes, there was a decreased bicarbonate level, which was corrected according to guidelines. LFT was within normal limits. Plasma ammonia was normal. ABG showed the respiratory alkalosis, probably due to hyperventilation. Ultrasound abdomen, there was a polylithiasis with bilateral grade 1 medical renal disease, and Doppler showed atheromatous calcific plaque in right carotid bulb with 5% to 10% stenosis. Urea was 43 and creatinine was 1.5. Echo showed EF of 64 and diastolic dysfunction was present. Imaging X-ray showed the bilateral reticulonodular opacities, and CT cyst showed bilateral atelectatic changes in the lower lobes. And CT brain showed diffuse cerebral involutional changes with mild periventricular small vessel ischemic changes. And because of the chest X-ray, the MANTO and ADA was performed, and ADA was found to be positive, and the patient was empirically started on anti-tuberculosis therapy, and the patient started recovery. And further going on, urine culture showed no growth, blood culture showed no growth, sputum culture showed Klebsiella, which was well taken care of by the antibiotics. And to proceed with this case, we performed the MRI brain with MR spectroscopy, which showed an altered signal intensity in the left anterior temporal lobe with features of cerebritis. And to proceed, we performed a lumbar puncture. There was a raised opening pressure, and the fluid that was aspirated was clear. The random blood sugar that was measured during the procedure was 254, and here we had a sugar of 76, and mostly the cells were lymphocytic. So lymphocyte predominance was there. And sending the CSF to CBNAT, we got MTB detected, and it is a significant titers. So positive findings in this case, the patient presented with an altered sensorium. There was a papilledema, and we found the patient had meningeal signs. And serum ADA and suggestive lesions in chest imaging was there, and the patient was started on ATT. And CSF analysis showed lymphocytosis, and CSF CBNAT was found to be positive. So final diagnosis is a case of acute infective meningoencephalitis of tuberculous etiology with antecedent pulmonary TB and recent CVA, probably due to TB vasculitis. Treatment: the patient was treated with anti-tuberculous therapy, corticosteroids, anti-epileptics, antiplatelets, and nephroprotectives. Course in the hospital, the patient was clinically diagnosed to have pulmonary tuberculosis, and the patient was started on anti-tuberculous therapy, rifampicin, isoniazid, and pyrazinamide. After starting ATT, the clinical status of the patient improved well. In view of search of evidence and diagnostic pickup by MRA, lumbar puncture was done, and the diagnosis of tuberculous meningoencephalitis was made. Patient was started on streptomycin and corticosteroids after diagnosing tuberculous meningoencephalitis, and the clinical status of the patient also improved remarkably, and the patient was discharged after 5 days after starting streptomycin. So moving on to discussion, classification of neuro-TB. It is an can be intracranial or spinal. Intracranial is again divided into tuberculous meningitis, tuberculous encephalopathy, vasculopathy, and CNS tuberculoma. Spinal TB can be classified into Pott's spine, Pott's paraplegia, and non-osseous spinal tuberculoma and spinal meningitis. This is a Lancet diagnostic criteria for TB meningitis. It has clinical criteria, CSF criteria, cerebral imaging criteria, and the evidence of tuberculosis elsewhere. Our patient had a systemic symptoms of suggestive of tuberculosis, had a recent history of CVA, had an altered consciousness, and CSF examination was clear, lymphocyte predominance was there, and CSF to plasma glucose ratio was less than 50. And there was an impact on cerebral imaging, and signs of TB were present on chest X-ray. So overall, it contributes to 13 out of 20 in the Lancet diagnostic criteria, and it is a case of definitive tuberculous meningoencephalitis according to this criteria. So stages of TB meningoencephalitis: stage 1 is non-specific symptoms and signs, no clouding of consciousness. Stage 2 is lethargy or behavioral changes, meningeal irritation signs will be present. Minor neurological deficits and cranial nerve palsies can be seen. Stage 3 is stupor or coma, abnormal movements, seizures, severe deficits such as paralysis can be there. So why this case is presented? It is a case of an elderly individual who is a known diabetic who presented with an altered sensorium with signs of meningeal irritation. She was diagnosed and confirmed to have TB meningoencephalitis with ATT and steroids. She was improved. Take-home messages and the points that I learned as a postgraduate from this case: meningitis is a common cause of unconsciousness and more common among diabetics and senior citizens. Early diagnosis and appropriate treatment will save lives. Thank you.
Okay, Rohit, what is the complications of TB meningitis?
Sir, TB meningitis and TB meningoencephalitis can cause vasculitis, leading on to secondary strokes, and can cause hydrocephalus, warranting shunt procedures.
Okay, thank you, Rohit. Thank you for
Thank
a
you,
nice opportunity. Thank you.
Thank you, sir.
That was an interesting case discussion we had today. The topic is open for discussion. As of now, we don't have much questions in the chat box. Let's say, doctors, you can unmute yourself and ask questions, or you can even post in the chat box during the course of the CME also. If there are no further questions, we'd like to thank both the speakers, Dr. Rohit and also Dr. Kannan, for his questions. We shall now move on to the second talk of today, which is on Sparkles, that is a case series in dermatology, which will be presented by a senior consultant dermatologist, Dr. Dadiv sir. Over to you, sir.
So good evening, everybody. I thank the organizers for introducing me to this meeting. So I've come with a series of cases, Sparklers 3. Next slide. So case 1. So here we present a 40 years old promiscuous male with multiple partners, mostly unprotected, and he presented with painless eruptions in the genitalia of 2 weeks duration. So on examination, a soft, moist plaque was seen rather than ulcer. A plaque was seen. It was very moist and it was oozing serous fluid. On general examination, he revealed, it revealed generalized lymphadenopathy was present and no mucosal involvement was there. And skin examination revealed multiple annular plaques with collarette of scales. So you can see the annular lesions in the neck and in the legs and also in the forearms and elsewhere he had annular lesions. So these lesions were very typical with scales in the periphery looking like a collar with the central pigmented area looking like a necrosis. You can see the similar lesions in the palms and a close-up of the lesion. You can see the collarette of scales. Any guesses?
Sir, Shankar, sir, syphilis.
Yes, it is secondary syphilis. Next. So investigations were done and the serous fluid which was oozing from the genitalia was examined for a dark ground microscopy. It was not contributory. And VDRL test was done. Initially, it was negative because of the prozone phenomena. And next, on serial dilutions, it was reactive in high dilutions, 1 in 128. And ELISA for HIV was negative. And diagnostic clues, the lesion, genital lesion, moist lesion was condyloma lata, which is a very specific lesion, a moist wart for lesion for secondary syphilis. And you can see the annular lesions with collarette of scales, that is the syphilis. And a positive serology, a high positive serology was pointing more towards secondary syphilis. The patient was treated with 3 doses of benzathine penicillin. And case 2, next. Here we present a patient, a 40 years old female patient with painless eruptions in both lower limbs of 3 months duration. And the lesions were crusted for the past 2 weeks. Still, there was no pain. And she was a known diabetic for the past 13 years. Any guesses?
Sir, neutrophilic ulcer, sir.
Anything? Diabetic for 13 years.
Necrobiasis lipoidica diabetic, sir.
No, next. So here, crusted lesions were present. This is a case of diabetic dermopathy. So feature of microangiopathy was present in this patient. And whenever you see such a lesion in a long-standing or a chronic diabetic patient, you have to take into account the vasculature of cardiac neurology, and especially eye. The patient will also be having eye changes. This is a case of diabetic dermopathy. Next, case 4. So here we present another patient with the generalized erythematous rash. Asymptomatic, it was painless, no itching was there. And this patient was treated with systemic steroids outside, and the lesions were waxing and waning with steroid and steroid withdrawal. Next. And the face and ears showed infiltrations of the skin. And he had no sensory loss, and no nerve thickening was seen, and no trophic changes or no clawing of hand or hammering of toes were present in this patient. Next. So here you can see the generalized erythematous rash with normal skin intervening in between. It's a very common case. Can you guess?
Sir, psoriasis versus steroid, sir.
Psoriasis, actually it's not psoriasis because scaling was not there.
Yes. Sir, it's collar scale, sir.
Which one?
Say, is it collar scale, sir?
No collar scales. No scaling was present. It was only an erythematous rash, plaques. No scaling, asymptomatic. When such a patient is presenting to us, you always look into the skin infiltration. You can see the infiltrated skin here and the normal skin intervening. This is actually, it's a case of BB Hansen's disease, mid-borderline Hansen's disease. The patient will always present with reactions. So that's why it, masquerades many inflammatory disorders, and we have a tendency to put him on steroids. Next. So skin biopsy revealed leprogranulomas, you can see here. Next. So case 5. So this is a very interesting case. The patient, a 16 years old boy presented with 3 months duration of acral melanosis. So that is pigmentation of the face, tongue, and the digits. Next slide. And he was anemic. Can you point the diagnosis? And this patient has become a vegan.
Addition, sir. Addition.
This patient has become a vegan 6 months back. Which vitamin is not present in vegan diet?
B12.
B12, sir. B12.
Yes, you are correct. So this is acral melanosis due to B12 deficiency. What test you will be doing for, not a B12 estimation, if you are not able to do B12 estimation, what bedside test you will do for this patient? Next slide.
Sir, peripheral
Next slide.
smear, sir. Hypersegmented neutrophil.
Yes. That's a very good answer, correct answer. Next slide. So you can see the hypersegmented neutrophils here along with the megaloblastic anemia. So this is a diagnostic point which will tell you the patient is having B12 deficiency, and the patient will get easily corrected with injection B12. Next. So case 6, this is the last case, interesting case. And this was a female patient, 40 years old female patient. She presented with yellowish papules protruding from the sides of the heels. So of long duration, it was almost some 10-15 years duration, and it was asymptomatic. Can you point the diagnosis? Very common disease, mostly unnoticed.
Familial hypercholesterolemia.
So it looks like xanthoma, but it is not xanthoma. Next slide. So I'll give you a clue. It becomes more prominent on weight-bearing position, and it resolves when the weight is removed. You can see the first slide, there is no papule, and the second slide, you can see the papules protruding out. So when the weight is released from the heel, the papules disappear, and when the weight is put on, pressure is given, it comes out. Pressure, piezo. Can you? Next slide. So it is piezogenic pedal papules. So piezogenic pedal papules are nothing but so very, curiosity. So small papillary herniations of subcutaneous tissue and adipose tissue, which herniate into the dermis. Okay, usually it occurs in the heel, and sometimes it can occur in the palms and wrist also. So this is pisogenic papules, pisogenic pedal papules. Next slide. So mostly it can be hereditary in most of the time, and it can happen in certain disorders where the connective tissue is altered. And in acquired cases, you can see in obese individuals and flat foot patients and patients who have a tendency to stand for a long period of time, and in athletes who have a high impact, who are involved in high impact sports also will develop this pisogenic pedal papules. So there's actually no need for treatment, you can reassure. But thing is that sometimes these herniations can become strangulated and it can become painful. So there you can excise the particular papule, you can excise. Next slide. So no treatment is required. Behavioral modification, weight reduction, and avoidance of high impact sports can be useful for these patients. So thank you for patient listening. And I wish you all a Merry Christmas and a Happy New Year in this occasion. Thank you so much. Thank you.
Tadesh sir.
Yes, sir.
Tadesh sir.
Yes, sir.
Sir, thank you for your wonderful presentation of various cases, along with your good flowers. Thank you, thank you. Very useful
Thank
for
you,
our
sir.
general
Thank you for the
practice.
compliments.
Okay, thank you. Happy Christmas, Happy New Year.
Wish you the same, sir. Thank you.
Thank you, sir. Wonderful cases.
Thank
I think the flowers are from your garden, sir.
Yes,
Flower
sir.
pictures.
Yes, sir.
Yeah, all the best. Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you, sir, for your excellent and highly informative talk. This topic is also open for discussion. If there are any questions, we request you all to unmute yourself and you can ask your queries. I think our chairman has a few questions he can ask them.
Yes, Tadesh.
Yes, sir.
I've been always wondering on your clinical acumen. Not only in dermatology, almost all dermatological problems are linked to internal medicine. That is where I am always concerned.
Sure, sir, sure.
Deficiency, you just put it as a different format of that, which is clinically presenting. I really appreciate your clinical, expertise and approach.
Thank you for your compliments, sir. Thank you.
Yes, I have done it on many occasions. I don't have any hesitation to repeat it. Thankful to Rajan for his contribution, especially
Thank you,
his passion for flowers. We often use the flowers from Rajan's garden. Today we have seen it from Tadayu's garden. It is always a pleasant flavor for all of us who are immersed in very, much in our clinical, issues of our patients. Now, going towards the discussions of the clinical case, I should really appreciate our neurologist, our second year postgraduate, for making a good diagnosis and management of the tuberculous meningoencephalitis. Here, three things are there. First of all, when a diabetic patient has come to you, you will have to make a diagnosis that it could be a neurological. That is most important. Secondly, where is the lesion? And whether it is in the brain or whether it is in the spine or whether it is in the meninges. And what is the cause for it? And all those things have been well documented and evaluated. And an important message is, when you want to prove tuberculosis, you will have to have either a sputum which is positive for AFB or any body fluid which is positive for AFB in the culture. Today with CBNAT, any fluid in the body you give it should be positive for CBNAT. Today CSF, they have done it and it has come out as positive. Thereby the diagnosis is well managed, proved as tuberculosis and is also managed. In tuberculous meningoencephalitis is usually a basal meningitis and an arachnoiditis. You need some steroids. You may be worried about the diabetic status of the patient, and that can very well be controlled by continuous insulin infusion or 2 hourly or 4 hourly, and steroids are needed. I should really congratulate our neurologist for giving a good result, and then the patient also went home nicely. Now we will go over to the, clinical albums. And the first is a patient with, a pneumonia in the, a patient came to us with cough and breathlessness. The X-ray chest showed a, left upper lobe lesion. If you see that lesion very clearly, there are translucencies in between. See here, there is a translucency, here is a translucency, here is a translucency. Common in pneumonia. You have air spaces, but when it is in the upper lobe, especially the apical lobe, the apical segment and posterior segment, the diagnosis should be always tuberculosis unless proved otherwise. This patient came to us with hemoptysis because he was already a PCI done and a stent is placed and he is on, antiplatelets. Here again, the confirmation is not radiological. Radiology will only suggest you it is possibly tuberculosis because of the location and cavities. But CB-NAT was positive in the sputum. That proves that this is a tuberculous, consolidation of the left upper lobe with, early cavitation, and 4 drug therapy has to be done. The patient is improving. Second is a very important, a very interesting clinical problem. I was there when this boy was brought to the emergency room. A 19-year-old boy was going on throwing fits and becoming unconscious. And he was referred from a place and people were giving all, anticonvulsant, this and that. But when I felt the pulse was very low, just connected him to the monitor, proved to be a complete heart block, a stroke Adams syndrome. I always used to say the cause for neurology may be in cardiology. Here it is proved. We tried with all sympathomimetic drugs to raise the pulse rate, it didn't improve. And our cardiologist was available and immediately rushed to the cath lab and put in a pacing, and the heart rate was raised to 80 and the patient became conscious. This again proves a complete heart block or a cardiac problem which reduces this the CNS circulation can present as seizures. His EEG was, I was very much particular that EEG has to be taken. They took it, it was normal. Then it is a cardiac cause. Now his pacemaker has been removed and he is going on well. Probably a myocarditis which is recovering. He is on follow-up. This, all of you see and we listen to Dr. The other you showing that it is a diabetes dermopathy. Fairly young chap with a chronic liver disease and a diabetes, both are uncontrolled. Both are uncontrolled. And this always leads to these dermatological problems, usually vascular. He very much rightly said that it is vascular. He can have retinal problem. He can have a renal problem. He can have cardiac problem. He can have CNS problem. Peripheral vascular also, which we will have to look into it. It does not need any separate therapy, but a strict control of diabetes is needed. With that, it will always improve. This is one of the common cause of jaundice in youngsters. And that too, it's a deep jaundice. Very much yellowish color and an obstructive type of a jaundice. Always think it could be a, Wilson disease. That, it is due to a copper abnormality. Okay? It is getting accumulated in the liver and causes a damage, and it leads on to a hepatic failure, and even a malignancy can occur. When you continue that. It is usually the clinical indicator is you check the, eye, the limbus, there is a ring there, which we call it the Kaiser-Fleischer ring, which our ophthalmologist will be able to see that even when it is very much prominent, even with the simple torchlight, you will be able to say, but better get it confirmed with the, ophthalmologist. This gives the clue. And serum free copper level must be high and ceruloplasmin must be low. That is the copper, handling enzyme is low. Therefore, it comes when it is very mild, it may respond to chelating agents like D-penicillamine, but sometimes it will go for decompensation. That stage, you will need a hepatic transplant. That will be the final answer. Many a times we have seen an abdominal pain, constipation, vomiting, and distension of the abdomen. The immediate clinical diagnosis is a bowel obstruction. That's what everybody thinks about it. Here also, this type of a shadow showed, a large colonic shadow, thought that it could be due to a colonic obstruction. A colonoscopy was normal, CT abdomen, everything suggested a large bowel obstruction. And we did a laparoscopy, and then the surgeon took out the bowel. There was no organic obstruction. This is a non-organic obstruction, probably a neurogenic cause for obstruction, and a pseudocolonic obstruction called Ogilvie's disease, and he was started on neostigmine and went well. What is the message from here is, then obstruction need not be an organic obstruction or physical obstruction, can be a neurological dislocation also, which you remember, and you can always treat the case with neostigmine. And here is a patient, many times we see lot of pulmonary tuberculosis with pleural effusions on the same side also. CT always tells us what is the level of the lung underlying and the pleura. When there is a recurrent effusion, I used to call it as inexhaustible effusion. Still, it could be tuberculosis, but you will have to think that it could be a collagen vascular disease. It can be a fungus, but above all, you must think that it is could be a malignancy. You can see, examine the pleural fluid for malignant cells. If it is there, it is fine. Otherwise, the final diagnosis has to be done through a pleural biopsy. You must do a thoracoscopy and do a pleural biopsy. Some of the radiologists under CT guided, they are able to do a pleural biopsy when there is a lot of thickening. But a pleural biopsy is needed to make a final diagnosis in cases of inexhaustible pleural effusion to rule out malignancy. Kindly remember in mind. This is an elderly gentleman, a chronic smoker with a COPD on irregular treatment. He came to a severe breathlessness. We call it an acute exacerbation of COPD. And we do ABG. It shows acidosis and hypoxia and hypercapnia. This is an indication for, a respiratory support. Need not always go in for an intubation and then do a support. A non-intubation or non-invasive ventilation can very well be done, and that can correct the carbon dioxide and pH abnormality and improve the patient also. After that, the bronchodilators, routine antibiotics can always be done. The message here is somebody who is acutely in a breathless state, you check the ABG, look for an acidosis, hypoxia, hypercapnia, and a simple non-invasive ventilation by the bedside for a few hours can improve the condition. Then antibiotics and bronchodilators can take over. Here it is a young man, a sea diver, and he came to us with the weakness of both limbs. And usually we think that it could be a decompression sickness, but it was ascending. In our 2 days time, he came with a leg and then one side and then other side, and it became almost a quadriparesis. And we thought two possibilities. One, it could be a decompression sickness with spinal cord damage, which many times we have seen the blood vessels getting blocked and the air bubbles are being seen. Secondly, we thought it could be, since it was going on changing and ascending, whether it could be an inflammatory demyelinating polyneuropathy. And even immunoglobulin was given, but he did not respond. But I was in favor of a decompression sickness because he had demyelination, you will have only lower motor neuron paralysis. Here it was an upper motor. The deep reflexes were very much brisk and the plantar was equivocal, and it is a transverse myelitis secondary to decompression sickness. It will take a long time to recover. The patient is still, struggling. It's a very interesting case. If you see here, the, lids, there is a ptosis this side more than this side. Here it is very much, open. A ptosis can be due to a neurological cause, or can be due to a muscular cause, or can be due to a mechanical cause. And to differentiate that, there is a simple test called as an ice pack. Keep it on the eye and see whether it improves. It improves means it is muscular cause, usually myasthenia gravis. And there is an hydrophonium or tensilon test that will also be very much useful. And these people need a continuous acetylcholinesterase inhibitors like pyridostigmine, atropine, steroids, immunoglobulin, sometimes even, plasmapheresis. This you will have to only see, you see the ptosis. As I said, you will have to rule out whether it is neurogen. Neurogenic means different. Cause is coming from third nerve. And if it is muscular means local. And it usually an inflammatory disorder. Or can be local eyelid lesion. That you will have to differentiate. This man proved to be a case of myasthenia gravis and responded well to pyridoxine and steroids. Thank you. Thank you all very much, ladies and...
Thank you, sir. Sir, may I ask one question, sir?
Yeah, please, please. Yes.
Sir, the soda obstruction, it could be a Hirschsprung disease, sir.
Yes, possible.
If you do biopsy, it will show aganglionic segments.
Yeah, but
If
here...
the patient is come again.
Yeah, because, I mean, Hirschsprung's disease, it's a localized disease. Here it was
Yes,
a
sir.
total. That is what the bowel also I had displayed. It is a total. I mean, it is not an aganglionic. I mean, ganglion is there, but action is not there. But it's a good suggestion. We must keep that
So
in
we do
mind.
biopsy, sir.
Yeah.
The
Actually,
ice pack test is very new to us, sir. Thank you. Ice pack test, very new to us.
yes, yes.
Thank
Actually,
you, sir. Thank you, sir. Thank you,
we
sir.
are all used to our tensilon or entroponian test. This is new one our neurologist, has brought in. And thank you all very much. Wish you all
Thank
a
you,
very
sir. Thank you.
Christmas and a happy, prosperous, healthy New Year 2024. We will meet in 2024. Thank you all.
Thank you, sir. Thank you. Thank you.
Thank you, sir, for all your valuable clinical discussions.